Hello, and welcome to this National MS Education Awareness Month teleconference, hosted by MS Focus, the Multiple Sclerosis Foundation, and made possible with support from Biogen, Novartis Pharmaceuticals, EMD Serono, Genentech, and Sanofi Genzyme. I'm your host, Casey Minnis. I'm Director of Communications for MS Focus, and I'm joined by Dr. Daniel Kantor, who will discuss the topic, What's in the Pipeline for Progressive MS? Please note there are slides available for this presentation, and in order to ask questions during the Q&A session following the presentation, you'll need to connect to the conference online. Go to readytalk.com and join with the access code 7766805. Again, to connect to see the slides or to ask questions, connect to readytalk.com and join with the access code 7766805. Now, allow me to tell you a bit about our speaker. Daniel Kantor, MD, is the past president of the Florida Society of Neurology, the former director of the Comprehensive MS Center at the University of Florida, Jacksonville, and he's currently in private practice in Coconut Creek, Florida. He's founder and president of the Medical Partnership for MS, and is the chief medical correspondent for MS World. He serves on the Healthcare Advisory Panel for MS Focus, the Multiple Sclerosis Foundation, and the Healthcare Advisory Committee of the Multiple Sclerosis Association of America. Dr. Kantor, thank you so much for being with us. Over to you.
Thank you so much for having me, and thank you to everyone at home for joining us on the Ides of March and really in the heart of March MS Awareness Month. It's so important to help raise public awareness about multiple sclerosis, and that means talking to your friends, talking to your neighbors. If you have the opportunity to go in the local news, talk a little bit about multiple sclerosis. You'd be surprised the number of people that still get confused between MS and other diagnoses. And I think a good thing to do during March Awareness Month is to also educate yourself further, and that's why I'm so happy that you're joining us for Changing the Focus, What's in the Pipeline for Progressive Multiple Sclerosis. Another way of talking about this, though, is to say the hope for more studies. And as you'll see today, where we used to not be able to tell you much about progressive multiple sclerosis, we are getting closer and closer. We're even getting closer potentially to FDA Approved Medications for primary progressive MS and maybe even further for secondary progressive multiple sclerosis. And what we're finding is that there are so many trials going on, you can't possibly review all of them at one time. But what's important to know is to think about what we understand about progressive MS, and as you hear about new medications, to not place all of your hens in one basket. To not get so super excited about any one treatment that you forget that there are other treatments that are being looked at as well. And one of the things that we've seen as we go to scientific conferences, and I've been attending conferences with a camera to bring you at home what's going on. Since 2009, I've been video recording my interaction with different scientists and doctors at the major MS conferences. Now I do that with MS World. And what you find is that what's exciting one year, 2 years later may not be as exciting, or what's not even heard of at 1 year may 3 years later become the biggest topic that we're talking about in multiple sclerosis. So I hope to give you a snapshot of what's going on right now in the world of MS, but realize that that is fast evolving, that's fast changing. Now, although we say that things are changing really fast, actually the idea of multiple sclerosis is actually an older idea. The first person to have had multiple sclerosis in recorded Western history was actually a person who fell and she was weak for several months and then she got better. Then she lost vision in one eye, followed by that she got better. But because this occurred at first while she was ice skating, the Catholic Church decided that she was a saint, and they named her the patron saint of ice skating. So Saint Lidwina, in the 1400s, what was happening is that she was having bad things happen followed by recoveries. And we think of that as being the hallmark of what we talk about in relapsing forms of multiple sclerosis. Now, we know that in MS in general, there seem to be people who have more relapsing types and people who have more progressive types. And some of us MS specialists aren't so sure of that separation between relapsing and progressive MS, and think that maybe a lot of people have both relapses as well as progression going on, and it might just be different at different times in your life. So how do we think we understand MS? Well, we think we understand it from what we learn from you, what we learn from people with the actual condition, with the actual diagnosis. And in 1903, Sir William Osler said that the best teaching is that taught by the patient himself. Now, he was in 1903, so we'll forget the chauvinism. He didn't say herself or themselves. But that idea that the best teaching that we can learn about multiple sclerosis is really what we have from you. And a well-informed person with multiple sclerosis makes for a better doctor-patient relationship, makes for a better neurologist, and makes for a better office visit for you. And when you're thinking about that office visit, we like to use this concept of MSTAR, or the Multiple Sclerosis Team Approach Rule. And it's a fairly simple idea, but the idea is that you, the person with MS, is the center of that MSTAR. And all the people on the one side, the primary care physician, the physical therapist, occupational therapist, speech and swallow therapist, the MS nurse, the case manager, the MS doctor, nurse practitioner, and physician assistant are all important, but we're there to be consultants for you. We're there to help back you up. It's the people on the other side that are even more important in your life, the friends and community, and often community, religious community as well, the significant other, the care partner, the family. All of these can become much more important in your life. But remember that you, the person with MS, is really the center of that MS team. Job can become very important in MS, both in terms of retaining your job, in terms of using the American with Disabilities Act and the idea of reasonable accommodations, and if the time warrants it, for applying for disability. This can become very important in different people's lives. And then the MS community as a whole. This means a community of not-for-profits, both large ones as well as smaller ones. And we know that in the United States, the three largest not-for-profits that deal with multiple sclerosis are the National MS Society with its chapters, the Multiple Sclerosis Foundation with its national headquarters in Fort Lauderdale and national services, and the Multiple Sclerosis Association of America with its national headquarters in Cherry Hill, New Jersey. Some of these not-for-profits are more about political advocacy, some are more about research, and other ones, like the Multiple Sclerosis Foundation, are more about actually improving your quality of life and actually being able to deliver services that can help you. And some of these services include educational services, and that's why during MS Awareness Month it's even more important to look online, find out which of the not-for-profits are having which type of seminars and which kind of teleconferences or web conferences or even in-person seminars that can help you understand more about multiple sclerosis. When we're trying to understand multiple sclerosis, I always think it's a good idea for us to take a step back and to make sure that we as physicians and you as people with MS and loved ones are using the same language. And we think of multiple sclerosis right now as being a lifetime autoimmune diagnosis. I say think because we're not entirely sure. In fact, half of what we know right now in medicine is going to be found out in 20 years to be wrong. And it's not just going to be wrong, it's going to be 180 degrees wrong. So it's going to be completely the opposite. The problem is right now we don't know what that's going to be in 20 years. We think of MS as affecting the central nervous system, and the central nervous system is made up of the brain, the optic nerves, as well as the cervical and thoracic spinal cord. And sometimes people ignore the spinal cord, but actually the spinal cord is the most common place where MS affects ever, as well as affects first. So the idea of tingling or weakness as being a symptom is usually from the spinal cord and not necessarily from the brain itself. The optic nerves are really involved, as well as the brain stem or the stalk where the brain sits on top. We think of MS as involving not just demyelination or loss of myelin, but also as axonal loss, or actually damage or breaking of those wires from the nerves. And we think of multiple sclerosis as occurring in genetically susceptible individuals who are exposed to some sort of environmental trigger. The problem is that we don't fully understand what's going on in terms of the genetics. We're learning more and more, and we now have almost 200 genes that have been associated with multiple sclerosis, and every day we're discovering new ones. But that doesn't mean that you necessarily have an MS gene, but there are things that can be associated. And as I'll talk about later today, we may be looking at this all wrong. It may be that there's something inside our genetics that's been there for a long time that gets woken up. And it gets woken up because of some sort of environmental trigger, and then what that can do is lead to the abnormalities that we see in terms of the immune system, but also in terms of the damage to the central nervous system that can lead to the symptoms of multiple sclerosis. When we look at the nerves themselves, those wires have a covering. We call that covering myelin. And what we think happens is we think that the immune steps that lead to neurological problems are that the activated T and B cells, so the activated immune cells, cross the blood-brain barrier and they launch an attack on the myelin, on the white matter covering, as well as on the nerve fibers themselves. And this can obstruct nerve signals. But this is what we talk about in general in terms of multiple sclerosis. But what about when we talk about progressive multiple sclerosis? When we talk about progressive multiple sclerosis, it may be that we're no longer having that abnormal immune response in the bloodstream. What's actually happening is we're just seeing that attack within the central nervous system, so within the brain, spinal cord, and optic nerve. So while people with relapsing forms of multiple sclerosis, we may be talking about a lot of different types of immune cells and cell messengers called cytokines that get released. When we're talking about progressive multiple sclerosis, we may no longer be talking about what's going on inside the bloodstream. It may be that all of this immune attack, if it's happening within the central nervous system itself. And there's some evidence for this. There's some people that believe this idea that there are follicles or collections of what we call B cells that are sitting inside the central nervous system of people with progressive multiple sclerosis. And what happens is that these B cells are going to be activated and they can cause damage within the central nervous system. Why that's important is because many of the medicines or treatments that we try to think about in terms of multiple sclerosis, we're giving into either the bloodstream, or we're giving it into the skin, or we're giving it into the muscle, or we're giving it into the gut because you're swallowing the pill, and it may not be crossing into past the blood-brain barrier into the brain and spinal cord to be able to have the effect that we need for it to have in progressive multiple sclerosis. And when we think about multiple sclerosis, we used to talk about 4 subtypes of MS, but about 1.5 to 2 years ago, we started changing our language, and we no longer really discuss progressive relapsing MS, the idea that you're at the same time progressing and having relapses. We call that a subset of primary progressive MS. But we think about relapsing remitting MS with this idea that people have waves of attacks that last for longer than 24 hours, but usually days to weeks to months, followed by times when they're not having new neurological problems, and they may every time be accumulating disability or accumulating problems, and that may turn into what we call secondary progressive multiple sclerosis, where you either continue to have the attacks or you no longer have the attacks, but you are still accumulating disability even without the attacks themselves. And then about 10 to 15% of people say, what are you talking about, good times and bad times? I have primary progressive multiple sclerosis, where things have just slowly been getting worse from the beginning. And sometimes we can look at what happens during an attack, and that can be even during relapsing remitting or secondary progressive, or as we're learning, even during primary progressive MS. But when we look at disability, when we think about relapsing remitting MS, the disability that happens is because of an attack. In secondary progressive MS, it can be because of the attacks, but it can also be in between the attacks, or even with no attacks anymore. And with primary progressive MS, it's happening even without there being attacks that are going on. So when we're thinking about treating multiple sclerosis, we use this idea of the triple threat in fighting MS. And when we think about this triple threat, on one side we're thinking about what can we do to change the course of multiple sclerosis? What can we do to be proactive? And we call that disease-modifying agents, disease-modifying therapy, or disease-modifying medications or drugs. On the whole other side, we think about all the symptoms. And what can we do to help individual symptoms that people with MS may be having? And then in the middle, if somebody is having an acute exacerbation or a relapse, less common in people with progressive MS, but still possible, then what can we do to shorten the amount of time? But for people with progressive MS who are still having too many attacks, the question is, are they on the right proactive medicine or the right disease-modifying therapy for them? So when we look back to 1992 and we look at how many FDA-approved medications there were for multiple sclerosis, the answer was 0. The first medication came out in 1993, but most of these medications, almost all of them, are actually approved for relapsing forms of multiple sclerosis. And now in 2017, as we stand right now, and things could change very soon, either this month or in the next few months, we have 13 separate branded products with one branded generic medication. That's an amazing leap forward if you think about it. We went from having 0 to having 13 separate branded products with one branded generic and 1 to 2 new medications coming per year. But when we look at terms of where we are in 2017 in secondary progressive multiple sclerosis, there's only one medication of those that's actually approved for secondary progressive MS, and that is mitoxantrone. And this medication is hardly used anymore because it's a chemotherapy that can have unwanted side effects as well. Now, many people with secondary progressive MS are still people in the world of relapsing MS, and so the other medications are available to them as well. But when we look specifically at primary progressive MS, as we stand right now in the middle of March 2017, there are no FDA-approved medications for primary progressive multiple sclerosis. So what's happened historically? Well, historically, we've had medications that came around for relapsing forms of MS. We had the interferons, we had glutamate acetates. Then we started having some IV medications, and then we started getting oral medications. And we have some medications that have been sent back by the regulators, and other medications that we had some studies done, but they're having more studies being done as well. But if you look specifically in terms of progressive multiple sclerosis, well, then that number becomes much lower. When we start thinking about it, the medicines we have for the symptoms of MS are relevant for people with progressive MS. But in terms of the medications that can disease modify or change the course of multiple sclerosis, there's a lot less medication. And as I said, there's one that's approved for secondary progressive MS, but for primary progressive multiple sclerosis, we haven't yet had a medication that's approved, and that may be changing very soon. So when we talk about these proactive medicines, what are our goals? Our goals of these MS disease-modifying therapies are to prevent relapses if people have them, as well as progression of physical disability. And no diet, unfortunately, has been proven to do this, and no supplement or vitamin has been proven to do this yet. Although, as you'll see, there are vitamins and other types of what we would traditionally call complementary and alternative medications that are being studied to see if they can have an effect on different forms of progressive multiple sclerosis. And this is very exciting, especially for those of us who are open to the idea that there may be complementary and alternative medications that can really help people with progressive forms of multiple sclerosis. So how do we disease modify progressive MS? What do we mean in terms of it? Well, we want to optimize your regular non-MS health. Meaning we want to control your other health conditions. We have to not forget that a person with multiple sclerosis has other things going on in their life. We want to think about diet. We want to think about exercise. We want to reduce the inflammation that's outside the central nervous system. But there may not be that much inflammation or swelling going on outside the central nervous system. We may want to reduce the inflammation that's going on inside the central nervous system itself if we think that is something active going on. We want to slow or even stop neurodegeneration. And really interestingly, we want to try to repair damaged myelin. We want to try to lead to remyelination. And where we're heading towards is repairing the damaged or the broken axons as well as the nerves themselves. And that's really the strategy that we want to take when we want to disease modify in progressive MS. So I think it's important to think about what we are talking about when we talk about changing the course of progressive multiple sclerosis. There's a focus on progressive MS like never before. Aside from the Multiple Sclerosis Foundation choosing to focus and change the focus this year and talk about progressive MS, last year for the first time we saw a conference that was completely dedicated to progressive multiple sclerosis. Patron's 2016, or the America's Committee on Treatment and Research in MS, focused specifically on progressive MS. And I know sometimes it can feel like if you have progressive MS that we aren't focusing on you enough and that we're not listening. I can promise you that scientists and doctors, neurologists have heard you loud and clear. Now when we go to medical conferences, people raise their hand and say, that's nice, but what about progressive MS? And in fact, there are conferences and there are sessions that are completely dedicated to try to figure out what's going on in terms of progressive multiple sclerosis. In that conference last year, there were lectures and posters that ranged and included things such as how progressive MS is similar to relapsing MS, but also how progressive MS is different. There was also a lot of discussion about what we can learn from successes in relapsing MS to help find a true treatment for progressive multiple sclerosis. There were 6 firsts at this conference. It was the first meeting to focus on progressive multiple sclerosis. MS World was the most visible nonprofit. There were the most videos that I filmed on one day. I actually filmed 34 videos talking to people about the exciting avenues that are happening in progressive MS. We had our first Spanish interview with English subtitles, actually. And the first time a person with MS actually followed us and asked to be interviewed on the air about what's going on. It was also the first time ever that I actually lost my voice from all that talking. What that means is that there's more focus than ever. Now, what are some of the possible disease-modifying therapies that we're learning about in progressive multiple sclerosis? Well, let's start with the medication that will hopefully be the next one to be FDA approved. And it may be FDA approved not just for relapsing forms of MS, but even for MS in general or for primary progressive MS. And none of us have a crystal ball to know exactly what the Food and Drug Administration is going to say, but ocrelizumab is a monoclonal antibody. So a monoclonal antibody, mono means one, clonal means they're all the same. Antibody is one thing that sticks to another thing. And what it sticks to is it sticks to these cells that are called B cells. So this is a type of immune cell. And in patients who received ocrelizumab, they received ocrelizumab every 6 months, like it was once and then 2 weeks later and then 6 months later and 2 weeks after that. And what happened is we not only studied it in 2 large trials of relapsing MS called OPERA-1 and OPERA-2, we actually studied it in a trial called Oratorio, where it was compared to not being treated with anything or to placebo, and what we saw were positive results for people with primary progressive multiple sclerosis. This is exciting because this means that it's the first time that we ever have a positive result from a primary progressive multiple sclerosis trial. And it means that for the first time, we could see medications that are approved for progressive forms of multiple sclerosis. Of course, one of the questions that's going to happen once we use this medication in the real world is how similar were the people in the studies to people who have had primary progressive multiple sclerosis for a long time. You couldn't be in the trial if you were in a wheelchair and all these sorts of things. And so the question is, are the people that we see in the real world going to be similar to the results that we saw in the clinical trial? And we're all excited to find out, and hopefully we should be finding out very, very soon. I mentioned that complementary alternative medicine has become a new focus in multiple sclerosis. Well, a vitamin, one of the B vitamins, also called biotin, was studied in France as an oral medication taken 3 times a day. And it seemed to actually help progressive forms of MS, but not the relapsing aspects of multiple sclerosis. And that is very exciting because that means that we might not just be looking at a treatment that helps relapsing MS but also helps progressive, but specifically a treatment that's helping progressive forms of multiple sclerosis. So we're all very excited that we've moved from just having results from France to now having an ongoing international phase 3 trial looking at it for progressive multiple sclerosis. At the end of 2016, we saw results for siponimod. Siponimod is an oral medication taken daily. And what it is it's a sphingosine-1-phosphate receptor modulator. And you may have heard of sphingosine-1-phosphate when you've heard about a medication called fingolimod or Gilenya. This medication is a little bit different and more specific. And it was studied not in relapsing MS only, but it was actually studied in people with secondary progressive multiple sclerosis. And the results that came out, the results that we've seen thus far have been positive. And that means that the FDA is starting to have those conversations with the manufacturer about what we need to do to move forward. Do we need more studies, or is this study going to be enough, and is the FDA going to look at it and potentially have a medication for secondary progressive multiple sclerosis? We talked about B cells with ocrelizumab. Other way of affecting B cells is a medication called ofatumumab, which is a subcutaneous injection given monthly. And it's being studied in relapsing MS, and it's being looked at potentially in primary progressive multiple sclerosis as well. Yet another exciting avenue where we may be able to help people with primary progressive multiple sclerosis. A colleague of mine who's actually trained with me is in Oregon, and she studied alpha-lipoic acid. So once again, returning to this idea of complementary and alternative medication. And the question was, could you give alpha-lipoic acid to people with secondary progressive multiple sclerosis, and would it help their MS in terms of their MS functioning and their walking, but also in terms of what we call brain atrophy? And atrophy means that we lose something. So when you don't use your muscles, they wither away. And as we get older, we all get a little bit more atrophy, but also our brains do atrophy. But when you have multiple sclerosis, that can happen, unfortunately, faster. And so the idea was that alpha-lipoic acid looked like it could actually slow down that decrease in what was going on in terms of brain volume. So we're all hoping for much larger trials that can help answer the question, but could this easy and cheap supplement be something that can help people with progressive forms of multiple sclerosis? And I know certainly that some people, even in anticipation of this and having seen the results, are already going ahead and taking this as a supplement as well. There are other medications that are being looked at. There are other medications that affect different aspects of both the immune system as well as the central nervous system. There are medications that are being looked at to not only stop the MS, but also to try to remyelinate, to form new myelin. And when you form new myelin, sometimes what you're able to do is make the axons or the wires themselves grow as well. Now, caution has to be said about stem cells. I understand the excitement around stem cells, the idea that there could be a cell in our body that becomes other cells. And we know that's how our body is formed. You take one sperm, one egg, 9 months later you have a fully formed human being. And so the idea is, could we take even your own cells and make them help to repair what's going on? Well, stem cells are finally being studied vigorously in MS. Most studies are focusing on relapsing MS, or at least not on primary progressive multiple sclerosis. And much of this research has to do with what we call hematopoietic stem cells. And hematopoietic stem cells are ones that are going to become different types of blood cells and different parts of the immune system. So the question is whether that would help progressive MS or not. Much more exciting for people with progressive MS are neuronal stem cells. And this may be more useful because the idea is, could you give somebody a cell that's going to become nerves or the covering of the nerves? So there's a little bit less research going on in that as well. There is a proposed secondary progressive MS trial going on in terms of oligodendrocyte progenitor cells, or cells that are going to become oligodendrocytes. And oligodendrocytes are the type of cells in your central nervous system that form the myelin, the white matter covering. In this trial, it would be injected directly into the brain. So not something that you take orally or something you take IV. So obviously we still need to go a lot further before this is ready for prime time. But the question that comes up is, what about the spinal cord? As I mentioned, a lot of times the spinal cord is involved even early in multiple sclerosis, but it's certainly in progressive multiple sclerosis. And if we're just dealing with the brain, are we missing parts of the central nervous system that are very important? What updates can we learn in terms of our understanding of progressive multiple sclerosis? And this is going to happen in parallel. We're going to further our understanding of progressive MS while at the same time developing medications and developing treatments that can help people with progressive multiple sclerosis. And so what we're understanding is that inflammation, these B cells and these T cells, may be stuck inside the central nervous system itself, or the CNS. We're learning more about the role of the mitochondria. The mitochondria is the energy factory of the cell. And we're learning more about how having a problem with your energy factory could actually lead to problems that could lead to progression in multiple sclerosis. And that's made some of us focus on what can we do to help fix the mitochondria or even to protect it from having damage happening. We're learning more about genes that are associated with progressive multiple sclerosis and how those genes may be sometimes similar and sometimes different to what we see in relapsing forms of multiple sclerosis. In terms of using MRI, many people may know, is sometimes seen as more useful in people with active relapsing forms of MS and maybe less useful in people with progressive. But what we are finding are that there are leptomeningeal, or the covering of the brain, enhancement. So there can actually be some brightness that's going on the covering of the brain, and this may be important in people with progressive multiple sclerosis. We are finding out that brain atrophy, or the shrinkage of the brain, may actually be a sign that's too late, and we have to intervene even earlier. And when we look at our clinical trials of progressive multiple sclerosis, even in carefully selected participants, so where we really make sure that we're using the right people in terms of studying progressive multiple sclerosis, even when we study people with primary progressive MS, still 1.5 to 2% of people are still having relapses. So although we stopped talking about this idea of progressive relapsing MS, it does appear that there are people with progressive MS who, despite the progression, are also having relapses or attacks of multiple sclerosis. And we're trying to understand how those people are similar or different to people with regular primary progressive multiple sclerosis. At the same time that we're having an update on our understanding of progressive MS, we're also having a real question of, do we really understand multiple sclerosis overall? And what I'm going to discuss now is something that you've probably never heard about before, but I think you will be hearing about more in the future. So for decades, we have talked about searching for the viral cause of MS. There's been many researchers all over the world who have proposed one virus or another virus to be the cause or to be the trigger for multiple sclerosis. And yet, despite that, we've never been able to definitively say that. What's interesting is that by having taken the human genome, and with the Human Genome Project, we've been able to actually go and basically write out a book that shows us the entire genes that are going on. And what we found out is that about 8 to 10% of that gene is not actually originally human. This may be a strange idea for you, but millions upon millions of years ago, material from viruses entered into our own DNA. And because it didn't kill us and maybe even actually offered some protection, it actually helped us in terms of other aspects. And some of us believe that when a baby is being implanted in the mother's placenta, that the genes that allow that to happen are actually come from a virus originally, millions upon millions of years ago. And so these viral aspects of DNA have been inside us for a long time. And then what happens, we think, is there's some sort of environmental trigger that happens right now. And maybe that is where the viruses like Epstein-Barr virus or human herpes virus or herpes simplex viruses, where those viruses then activate this DNA that's inside our own body. And it starts making a protein. And that protein, you can see 1,000 times higher in people with multiple sclerosis than people without multiple sclerosis. And it looks like that protein may be able to cause neuroinflammation as well as neurodegeneration and even prevent remyelination from going on. And so the hope is that if we can't turn off that DNA, if we can't turn off that from happening, and we can't stop that environmental trigger, maybe what we could do is block that protein from having an effect. And that's why right now what's being studied is an antibody that sticks to that protein and neutralizes it so that your body can't keep creating this protein that is causing neuroinflammation, neurodegeneration, and even preventing your body from having remyelination. This idea may sound foreign to you because it is foreign. The idea that there's foreign DNA within our bodies is a newer concept that's been happening over the past several decades, but really starting to be looked at by scientists. And really we're starting to look at different autoimmune diagnoses, not just in multiple sclerosis and diabetes type 1 and rheumatoid arthritis, in other autoimmune diagnoses. And in fact, it could be something that links these different autoimmune diagnoses together. And the question is why our body starts to, it seems, to attack itself. And maybe what happens is we have this DNA inside us that gets activated and creates this protein that then causes this problem. Well, we're going to learn a lot more in October 2017 because in October 2017, we're going to see results from a phase 2B trial in relapsing remitting multiple sclerosis. Now, why is that important for people with progressive multiple sclerosis? Because depending on the results of what we see, this study is actually looking a lot at remyelination as well. And what we may see is that it looks like this blocking this protein actually does help to slow down multiple sclerosis and does help even to help us have remyelination where our body can go and form new myelin as well. And so I think it's going to be very important for people, whether they have relapsing MS or progressive multiple sclerosis, to keep an eye out for October 2017. And I can promise you that we will keep you updated in terms of what the results are as well. I talked about the triple threat in terms of treating multiple sclerosis, where you don't just think about disease modifying. You also think about symptomatic treatment. And symptomatic treatment can be very important not just for people with relapsing MS, but potentially even more important for people with progressive multiple sclerosis. And that's where we're looking at what happens even in between attacks, or if you don't have attacks, what's happening on a day-to-day basis. And MS symptoms can be almost anything. You know, you go to Dr. Google, the world's most famous doctor, you type in almost any symptom, you're going to find multiple sclerosis. Where for a lot of people it can be sensory problems, it can be motor problems, it can be weakness, it can involve the eyes, it can involve double vision, it can involve walking, it can involve cognition, so thinking. It can involve the bowel and bladder as well as sexual dysfunction as well. And almost anything that you can think of could actually be a symptom of multiple sclerosis. And that's why it's so important to work with your neurologist in terms of what symptoms you're having and what they can do about them and what they think are coming from the MS or what may be coming from something else. And that's why I think when you're thinking about fixing these different symptoms, it's important to categorize them. And the way I like to do that is to talk about visible symptoms, to talk about invisible symptoms, as well as to talk about private symptoms. So an example of a visible symptom of multiple sclerosis could be if you're having walking problems. So if you're using a cane or walker or a wheelchair, that's something that somebody outside of you could see what's going on. Somebody across the street would be able to tell that something is just not right. That's a visible symptom of multiple sclerosis. In terms of invisible symptoms, if you're having fatigue or if you're having the spin, so vertigo, or depression or problems with your thinking, these will be invisible symptoms that somebody outside may not know is going on with you. And if you don't share those symptoms with your doctor, they may not know what's going on, and they may not know how important that symptom is. And so when you're going with a walker or a wheelchair to a doctor, they may think that's your most important symptom, but it might not be. That may be something that you're used to, or maybe something that you've figured out ways of incorporating to your life. But having problems with remembering that word that you're looking for, what's that word on the tip of your tongue, or remembering people's names, or remembering what happened right before now, all those things may be more important to you, and so it's important to make sure that your neurologist understands what you think is important. And then there are private symptoms. So private symptom of multiple sclerosis, for example, could be sexual dysfunction. It's not something that somebody across the street would know is going on, but it's not invisible to your care partner. And unless you go and share that private symptom with your neurologist and with your healthcare team, there's no way we can go and make an intervention that can help think about the treatment. And for each of these aspects of multiple sclerosis, what's happening is we're getting better and better. We're getting better at handling what we call neurogenic bladder, or problems where the nerves don't communicate well with the bladder. All the time, there's new treatment options that are being opened up to people with this sort of condition. In terms of spasticity or muscle tightness, we're always thinking about ways that we can go and make it even easier, and ways that we can take our medications and make them even better. So these symptoms of multiple sclerosis can be so different, and so it's so important for you to think before your office visits, what are the symptoms that you're going to talk to your doctor about, which symptoms you want to bring up, and which symptoms you want them to handle first. Try to prioritize them so that your doctor can do a better job of being your neurologist and can do a better job of figuring out what they themselves can fix and what things they might need one of their partners to help with. Do they need another specialist who's also a physician? Do they need a physical or occupational or speech therapist to help them? What can they help you with in terms of education? Where can they maybe help you with even vocational rehabilitation? Where can medications help? And what factors also play a role that can make your symptoms come out? So is heat a major problem? And that's where the Multiple Sclerosis Foundation is so great in having a cooling program where it can actually help people who feel like their symptoms are worsened by heat, what we call UTOF phenomenon, to be able to afford and even to for a lot of people to be able to give them with no cost to them cooling devices that can help them in terms of making sure that you don't have too much external heat going on that can bring out older symptoms of your multiple sclerosis. So I hope that what we've seen today is how this idea of the multiple sclerosis team approach rule with you as a person with MS at the center can be both motivated, educated, and empowered to really help each other. And by helping each other, what we can do is take these individual MSTARs, and they can help each other in terms of the multiple sclerosis patient network. What I think is exciting is that we used to say, well, we have a lot more research in relapsing MS than ever before. But now we have a lot more research in progressive MS than ever before. If you go to clinicaltrials.gov and you type in progressive multiple sclerosis, you're going to find a lot of clinical trials going on outside the United States as well as within the United States, and maybe even some of them close by to you. And that means that when we open up our journal for neurology, it used to be there was very little about MS. Now, 3/4 of what we read about has to do with multiple sclerosis, and increasingly that's about progressive multiple sclerosis as well. And so while it may have felt for a long time that if you have progressive MS, there's not much to listen to, all you keep hearing about is relapsing, what you have to understand is you may be hearing that on the radio waves in terms of the internet, in terms of what you hear on television even, you may be hearing that because of what's been already FDA approved. But there's a lot more research going on in terms of the future. And I really, truly hope that together we can make the multiple sclerosis team approach rule turn into the multiple sclerosis team approach reality. I'd like to thank you all so much for your attention, and I'd love to open up to questions. But as a reminder, unfortunately, if you're on the telephone call, you can't ask a question unless you actually log on to the computer as well. And so Casey gave that information about ReadyTalk, ReadyTalk.com, and you type in the confirmation code 7766805, and there you can log on to ask questions. And we'll be more than happy to hear any questions that you may have. Thank you so much for your attention, and thank you to the Multiple Sclerosis Foundation.
All right, folks. As Dr. Kantor said, if you have questions, you can log on at ReadyTalk.com and use access code For those of you already online, you can click the Raise Hand button, or you can use chat to ask your question. While you're taking a minute to type in your questions into chat, I would like to just mention that the cooling program that Dr. Kantor mentioned is in cycle right now, and from now until June, you can apply online at www.msfocus.org. All right. Let's see if we have some hands raised. We do. Give me just a minute. And our first question is from Dana Bradbury. Dana, you're on the line. Dana, are you with us? Okay. Well, we have some questions through chat. Tracy Jocelyn asks, what will be the first secondary progressive clinical trial to be approved, and how much longer?
Excellent question. So the question was, we have treatments for relapsing forms of multiple sclerosis. So what will be the first for secondary progressive MS? The first thing, we already have the first for secondary progressive MS because mitoxantrone, as I said, has been approved for a while for secondary progressive MS, although it's not used very often at all nowadays. So the question is really what's going to be in the future for secondary progressive MS. Remember that many people with secondary progressive MS have what we call a relapsing form of multiple sclerosis, and so the 13 separate branded products with one brand generic are available to people with secondary progressive multiple sclerosis. But in terms of a specific secondary progressive MS medication, we're going to have to see a few things. One is how the Food and Drug Administration is going to give the label. Right now, the Food and Drug Administration basically has two different labels for multiple sclerosis. Well, it has three, but one of them is for relapsing forms of MS, and the other one says for relapsing forms of MS if you've had an inadequate response to two or more therapies. The third one is specifically for mitoxantrone, where it says for worsening, relapsing, remitting, or for secondary progressive. The medication that I mentioned called siponimod, an oral medication given once a day, is probably going to be the first time that we see whether the FDA, the Food and Drug Administration, is going to approve a medication specifically for secondary progressive multiple sclerosis. We're not sure if they're going to make the manufacturers do another clinical study or if the clinical study that we've already seen the results for are going to be enough. So that's really going to play a big role in terms of whether we're going to see this medication come out next year, early next year, or whether it's going to be longer than that. Because if the Food and Drug Administration asks for another clinical study, well, then that's obviously going to take several more years. We're going to find out what happens in terms of the Food and Drug Administration in the next month or so. They're having those conversations. And so fairly soon, we should have a much clearer idea when the next secondary progressive multiple sclerosis drug will be on the market.
Tracy followed up and asked if you could please spell that.
Sure. Siponimod is SIPONIMOD.
Okay. Thank you very much. We now have a question from Ronell who asks, how much biotin should be taken 3 times a day?
The question was about biotin. So the first question is whether it should be taken right now before the results of the clinical trial. The reason for that is because some people have proposed that taking such high doses, and this is much higher doses than when people think about their nails or hair, the amount used in the clinical study is 100 milligrams 3 times a day. And what I often see is neurologists saying to their patients, okay, go ahead and take biotin, take 300 milligrams once a day, because they haven't actually seen the results of the trial. So the trial was 100 3 times a day. It may be that it's important to take 3 times a day. We might find out it's not. But since that's how it was studied, when I do have people who, in anticipation of the results, want to take it, then what I do is I personally do it at 103 times a day.
All right. Folks, we seem to be having difficulty with the raised hands. I'm going to ask that if you have a question, please do submit it via chat, and we'll ask that question for you. All right, so our next question, have we gotten any closer to the FDA approval on ocrelizumab? And this question is from Marie.
The question was about ocrelizumab. So ocrelizumab is that medication that we're expecting very soon to have an answer from the Food and Drug Administration. We actually have breakthrough status with that medication, meaning the FDA is supposed to give the answer much faster than normal, and that was supposed to be at the end of December, so actually December 28, 2016. At that time, the decision was pushed off, and it was pushed off to a new date of March 28, 2017, so this month. The question is whether we're going to really hear it this month or not. And like I say, a crystal ball around what goes on with the Food and Drug Administration is very, very difficult. And so to know for sure whether we're going to hear it this month or not, I can't predict. But we should be hearing very soon, either this month or if not this month, then very soon. And we should be hearing a couple of questions that we have. One is, what's the label going to say? Meaning, is it going to say for MS in general? Is it going to say relapsing MS and primary progressive MS? What's that language going to look like? And I think it's going to be very hard for us to predict it before seeing, but I think we're all excited because we can sit at the edge of our seats knowing that very soon we're going to find out.
All right, our next question is from Susan. And also, Joe asked a similar question. They're wondering about the cutoff age for ocrelizumab. Joe asked why the cutoff age was 55, and Susan mentioned that she was told it wouldn't be effective to use at 68 years old. Why is that?
Let's talk about what goes on in clinical trials. In clinical trials, we study people who are very similar to each other. And the reason you do that is because you want to make sure that the results that happen on treatment A versus treatment B, or on treatment A versus what we call placebo, meaning no treatment, we want to make sure that the results that we see are really from the difference in the treatment and not because you have some people who have vastly different types of MS or vastly different ages. And that's why there's an age range in clinical trials. And what happens is we also don't want there to be too many side effects that happen during the clinical studies, because then you're not going to know, is it a side effect of the medication or is it because people as they get older have other medical conditions going on as well. So it's not strange that ocrelizumab had age range. Actually, all of our medications have age ranges when they're being studied. And 55 is meant 60, but 55 is the usual cutoff, 18 to 55, for most of our clinical trials in multiple sclerosis. You may just be noticing it now because you're looking into that medication, but if you look at the other medicines and how they're studied in very similar ways. But that shouldn't be misinterpreted to mean that if you're over 55, that the medicine's not right for you. We don't have any reason to necessarily think that. And just like we don't with our other medications, we don't say, oh, you're over 55. Well, if that medication wasn't studied, then we don't give it to you. No, we still give it to people without regard to their age. Where it becomes an issue with age is more when we're talking about younger people. And so when we're talking about children have different things going on than adults. They have development still going on. They have growth. They have other things going on besides their multiple sclerosis. You think about bone health and you think about neurodevelopment and all these things. And so that's why specifically the FDA usually requires there to be a pediatric or a childhood study going on after there's the adult study going on as well. So just because you're 68 does not mean that ocrelizumab is not the right medication for you. And in fact, I'd wager that a lot of people who are 68 are going to go on this medication.
Our next question is from Ronell. She says, most of our patient files state MS, not which type. Do you anticipate trouble with insurance companies changing when it's available for a primary progressive drug, and then if it's necessary to switch back to a relapsing remitting drug?
An excellent question. The question was about some of the more practical issues that go on in the field of medicine, in the field of neurology. And the question is how we label you as physicians, how important that is, and how important that is to the insurance companies. Many of your files actually don't just say MS. They actually do say what the doctor thinks the subtype of multiple sclerosis is. And for many years now, insurance companies actually have been asking us what type of multiple sclerosis your patient has. What's going to be interesting and troubling is if we have a medication that's approved specifically for primary progressive MS, so we have reason scientifically to think, let's say, that it would be helpful for people with relapsing forms of MS. What may happen is the insurance company may say, well, no, you've said that this person has primary progressive MS, so they can only get that medication, or no, you've said that person has relapsing MS, well, then they can't get that medication that's for primary progressive multiple sclerosis. Unfortunately, this is something that happens sometimes nowadays, and it's something that may happen more in the future, and that's why it's so important that when medications get studied for one type of MS, we do usually study them for other types of MS to see if they could be useful for them as well.
All right. And now we have a question from Tara. She asks, can you speak about Lemtrada? Are there any studies on it for progressive MS?
The medication Lemtrada, like the medication ocrelizumab, is an IV medication. So it's given into your vein. You don't get it at home. Someone doesn't come to your house. You go into an infusion center. IV Lemtrada or alemtuzumab is FDA approved for people with relapsing forms of multiple sclerosis who have had an inadequate response to 2 or more therapies. Now, it was studied since the mid-90s and since the early 90s actually in England. And there it was developed at the Cambridge Department of Pathology, and that's why its original name was CAMPath, or Cambridge Department of Pathology. And it was first used for certain types of cancers, but then the Department of Neurology, which was right there, decided to start using it for people with multiple sclerosis. And in fact, it was first used for people with progressive forms of multiple sclerosis. And their original studies looking at progressive forms of multiple sclerosis actually did seem to help the people, but it was more dramatic when it was used to treat people with relapsing remitting multiple sclerosis. And that's why the shift happened, where instead of being looked at for just progressive MS, it started being looked at for relapsing multiple sclerosis. So those original studies actually help us in understanding in terms of what it could potentially do for people with progressive MS, although because those studies weren't big enough or for long enough, it's not in the Food and Drug Administration's label, and it's not FDA approved specifically for progressive multiple sclerosis. Another thing that medication, alemtuzumab or Lemtrada, does, which is also not in its packaging or its labeling, is it actually can lead to confirmed disability improvement, meaning people actually have improvement in terms of their disability while on it. And the question is, how progressive could a person be that they would still have that response? And we don't fully know the answer to that.
All right, we have time for one more question. And we have a question from Harriet. With ocrelizumab probably being approved at the end of the month, I understand that rituximab is almost as effective. Is it worthwhile to use rituximab, a less costly drug, rather than ocrelizumab?
It's an excellent question. The question is, ocrelizumab is a humanized version of a medication that's been around called rituximab. Rituximab also depletes or pushes down the B cells, but it's a chimeric molecule, meaning it's a mixture of animal as well as human. And rituximab was studied in relapsing MS as well as in primary progressive MS. Unfortunately, in the Olympus trial, which studied in primary progressive MS, it was not positive, meaning that the rituximab did not delay the progression in people with primary progressive MS. But when you look at that study and you looked at people who were who were younger, and you looked at people who had more inflammation going on, those people, it actually did seem to help them. But because of that result, rituximab was not studied further in major ways, and so ocrelizumab was studied because it was felt that a fully humanized version makes more sense. With that said, in Sweden, rituximab is the most used disease-modifying agent for multiple sclerosis because of the results that we've seen in relapsing forms as well as in progressive forms of multiple sclerosis. What I think is going to happen is that once the FDA approves ocrelizumab, and it's still not clear exactly what's going to say in the label, but once it approves it, it's going to be a lot easier for people to get ocrelizumab than to get rituximab. What I mean by that is insurance companies, like doctors, oftentimes are a little bit wary of doing too many things that are off-label, especially when they have an alternative that is actually FDA approved. And so I think that what we're going to see is that the ocrelizumab is easier for people to obtain. Now, whether ocrelizumab and rituximab are the same strength is also something we don't know. They work a tiny bit differently or a little bit differently, and it may be that ocrelizumab is a little more powerful, but once again, we haven't seen a study comparing them, and I doubt that we will. That's an excellent question.
Well, that's all we have time for now. I'd like to remind everyone that if you missed any part of this program, it will be rebroadcast on msfocusradio.org and available on demand later this month. Follow the Multiple Sclerosis Foundation's Facebook, Twitter, or Instagram for times and access information. Our sincere thanks to our sponsors for their support of this program, to all of our listeners and to the many people who participated by asking questions, and especially thank you to Dr. Daniel Kantor. Thank you so much for all of this wonderful, hopeful information.
Thank you, and have a good night.
Good night, everyone.